Hi everybody, Deb Constine here, part of our core team that is attending EULAR 2024. I'm in Madison, Wisconsin, longtime volunteer of AI arthritis, and I have rheumatoid arthritis for the last 43 years, diagnosed at 13. The session I dug into today, and the reason I'm looking down is I have lots of notes in front of me, so just so you know why I'm not peeking up all the time. The session I chose was patient-tailored pain management in RMDs. RMDs are rheumatological musculoskeletal diseases, are rheumatology type diseases. And the professor that did this session was Professor Neil Basow, B-A-S-U, if I'm pronouncing that incorrectly. He's the professor of musculoskeletal disease in the University of Glasgow. And one thing that he did focus on was he doesn't blame patients for their number one priority being pain. So it was ranked pain, fatigue, valued activities, low mood, mobility, activities of daily living, and then visible joint damage. And clearly I have visible joint damage. And this was consistent across any rheumatological disease, and like psoriatic arthritis, lupus, all of them are included. He did talk about the impacts of all aspects of patient life, being functional activities, social consequences, the economic burden, and emotional well-being. So those are all the things that impact patients on a daily basis. And as we've all seen, that they call it the visual VAS. It is the 1 through 10 pain number system, and it's got like from 0 pain, and you've got a smiley face, and at 10 they have tears and crying and things like that. He said that is not the way we should be looking at pain at this point. We should be looking at it as an entire multi-dimensional disease and problem. And he talked about mapping out the different areas of the brain that are affected by pain as well. He delved deep into 3 mechanism descriptors of pain. The number 1 was nociceptive. Now, that is pain that arises from actual damage or something that causes tissue issues. And it is like an example of that would be inflammation in the joint or a broken bone for that matter. The second one was neuropathic. That is pain that is caused by the somatico-sensory nervous system. And I know I said that kind of butchered a bit, but what that is actually talking about is part of our sensory system that causes perception of touch, pressure, pain, temperature, things like that. So you understand what that is talking about. And that, an example of that would be like vasculitis. It's a neuropathic pain disorder. RA would be a nociceptive, so that number 1, that was an example of that as well. So that inflammation in the joint. And then the third piece, which he spent a lot of time on, was the Nociplastic. And that is pain that happens from an altered, there's no clear evidence of there actually is an issue. I could say that I have a nociplastic pain sensation right here, but you can see that there's nothing there. There's no bruise. There's no evidence of a trauma or something like that. And things that they threw into this category was fibromyalgia as well as hypermobility, things like that. There's no clear evidence. And when they talked about what to do about this third area, which is the nociplastic pain, they recommended going to the EULAR recommendations, and you do a lot of education and exercise, those pieces that they thought that it tended to have a really good influence on people's pain in their body. And they also talked about the importance to treat the symptoms that are related to pain. So the fatigue, the anxiety, the depression, all of those things too. They talked about those can be equally as important as the pain that you're feeling. And they said when the exercise and education, when that is not enough, that you need to actually start looking at treating all of the things that are happening alongside of the pain. For some people, they can do it in a pharmacological way. If you're having sleep disturbances or anxiety, there's medications you can take. But they talked about the non-pharmacological management and looking at basically a constant behavioral therapy. So people talking to you, and that can be even over the phone, talking to a counselor, but that being all the time, as well as exercise therapy. That can actually be also done, as well as visual care is what they interpreted it into being more the educational that happens. And let's see, so a couple other things that I wanted to quickly talk about was they actually talked about the functional MRI brain imaging. So it can actually look at the oxygenated and deoxygenated hemoglobin, so the blood in your brain, and measure it as far as the activity goes and what's happening. And they're actually experimenting. Nothing is out there right now, but they're really doing some research into the functional brain imaging and looking at very specific of the brain and looking at that. They think that certain areas of the brain are talking to each other, and they're looking at the focus on that. So there was something called, at the very end, it was called the TMS. It's a magnetic, like a magnetic treatment. So something like a tool was put on the brain, and it is called Transcranial modulation. And it's using magnets and trying to target certain parts of the brain to use a significant magnetic impulse to that specific part of your brain. And they're seeing that is having really good observation on the outcome of pain. Really interesting study. And there's more to come because they say that this is an ongoing thing and we need to make sure we're really driving it because it's the number one priority for patients, as most of us understand that for sure. So stay tuned, more to come.